This film demonstrates two methods of estimating the output of the heart in man. The volume of blood ejected by this living pump has long been the subject of interest. One early attempt to measure its output was made by the Reverend Stephen Hales soon after he became Vicar of Teddington in 1710.
Having bled a sheep to death, I fixed a musket barrel to the pulmonary vein near its entrance into the left auricle. Then, placing the barrel in a perpendicular posture with a funnel on the top of it, I poured in melted beeswax. This perpendicular height of melted wax, which was near 4 feet, would not have filled the auricle and ventricle if I had not at the same time taken care to pass a small brass pipe through one of the ascending branches of the aorta into the left ventricle, through which the air passed off as the wax entered into the ventricle, the brass pipe being at the same time gradually drawn up by an assistant. I was by this means assured of the force with which the injected cavity of the heart was dilated, which is more uncertain with a syringe. This dilating force continued acting uniformly until the wax was grown stiff and hard. Then, taking out the wax which was formed in the shape of the ventricle, this is the proper cavity of the left ventricle just before its contraction. This piece of wax thus formed may reasonably be taken to be nearly commensurate to the quantity of blood received into this ventricle at each diastole, and is thence propelled into the aorta at the subsequent systoles. The sheep was 3 years old and weighed 91 pounds alive. Its pulses beat 65 times in the minute. The capacity of the left ventricle of his heart was equal to 1.85 cubic inches.
There seemed, however, to be no way in which the problem could be solved in intact man until Fick outlined a possible method of approach in 1870. All the blood pumped by the right side of the heart passes through the lungs, where it becomes fully oxygenated and bright red. In any individual resting man, the rate of oxygen uptake is fairly uniform, say 240 cubic centimeters per minute. When bright red, fully oxygenated blood is flowing quickly through the tissues, each unit volume of blood will give up a little oxygen, represented here by one tiny bubble per corpuscle. As it does so, it becomes slightly dark in color. This blood returns to the right heart and thence passes through the lungs, where each unit volume will only take up a similar small amount of oxygen in becoming saturated. This is shown again as one tiny bubble of oxygen to each corpuscle. If we imagine that this small uptake of oxygen is 40 cubic centimeters to each liter of blood, and the lungs are in fact taking up 240 cubic centimeters of oxygen per minute, then 6 liters of blood must be flowing through the lungs in a minute, and this is, of course, the cardiac output. If the blood is flowing through the tissues at half this rate, the oxygen needs of the tissues would only be met if each unit of blood gave up twice as much oxygen. Diagrammatically, each corpuscle gives up 2 tiny bubbles of oxygen, and in doing so the blood becomes much darker in color. Each unit of blood, now arriving at the lungs, takes up twice as much oxygen as before in becoming fully saturated. Diagrammatically, each corpuscle takes up 2 tiny bubbles in becoming fully oxygenated, which is 80 cubic centimeters per liter instead of 40 as in the previous example. The oxygen needs of the resting man are still 240 cubic centimeters per minute, and the lung blood flow or cardiac output is thus 240 over 80 or 3 liters per minute. Therefore, in order to estimate the output of the heart in man, we have to measure the rate of oxygen absorption in the lungs and the arteriovenous oxygen difference, which is the amount of oxygen taken up by mixed venous blood on its way through the lungs. In practice, the subject on whom the estimation is required lies comfortably on a padded X-ray couch. In order to measure his oxygen uptake, a spirometer is used, the air in the bell of which is enriched with oxygen from a cylinder. The spirometer mouthpiece is fitted in front of the subject's teeth and behind his lips. While the nostrils are closed by a comfortable sponge rubber spring clip to make an airtight connection. The absence of leakage at the nose and mouth is ensured by testing. The tap is then turned, enabling the subject to breathe to and from the spirometer. The spirometer bell rises and falls with each respiration, and these movements are written by an attached pen on a revolving drum. As all the exhaled carbon dioxide is absorbed by soda lime, the volume of the spirometer decreases owing to the absorption of oxygen in the lungs. The rate at which oxygen is absorbed is represented by the upward slope of the respiratory tracing. On the paper on which the tracing has been made, minute intervals are marked by vertical lines. The changes in volume are measured on a vertical scale. A line is ruled corresponding exactly to the slope of the tracing. 10 minutes are counted and the scale volumes are read at the beginning and end of this period. The difference is the volume of oxygen consumed in 10 minutes. Hence, oxygen consumption by this individual in a minute is 235 cubic centimeters. We now proceed to sample mixed venous blood. Werner Forssmann, responsible for developing the technique of direct sampling of blood from the right side of the heart.
In the summer of 1929, I conceived the idea that a thin, flexible ureteric catheter could be inserted along the veins into the heart without harm. In the Augusta Victoria Hospital at Eberswalde, near Berlin, I myself exposed a vein at my left elbow and inserted this small catheter.
He then walked to the X-ray room and arranged a mirror in front of the screen so that he could follow the passage of the catheter into his own heart. Here is the actual radiograph taken at the time. He felt nothing and there were no ill effects.
Later on, I passed a thicker catheter. And on 2 occasions I tried to obtain pictures of my heart outlined by radio-opaque injections. During the following 2 years, I catheterized my heart 9 times through different veins without any unpleasant sensations or other trouble. This seemed adequate proof of the safety of the method.
Dr. Forssmann was aged 25 when he conducted these experiments on himself, in the process of which he used all the available superficial veins on both elbows and the saphenous veins in both thighs. Now let us return to our demonstration. Catheterization of the heart must be carried out with all sterile precautions. A sterilized catheter is taken from its storage tube. A syringe is attached and the catheter is flushed through with saline solution. It is then ready for insertion and is placed in an accessible position on the sterile instrument tray. We proceed to prepare the arm of our patient for the insertion of the catheter. The possibility of leaving a cardiac catheter in position for a sufficient length of time to make serial observations on the behavior of the heart was first realized by Dr. André Cournant and his colleagues, who published their method in 1941. A local anesthetic, in this case 2% procaine solution, is injected into the skin and subcutaneous tissues over and around the median basilic vein at the bend of the elbow. When the skin has been made insensitive, a small transverse cut is made over the vein, the incision being opened up with forceps. The vein is picked up and 2 ligatures are passed round it. The lower ligature is tied firmly, while the upper is simply a loop by which about ½ an inch of vein is supported, while an opening is made into it with scissors. The catheter, with saline dripping from its tip, is then inserted with its concave curve facing medially. Once the catheter has entered the vein, the wound is covered by sterile swabs, and the catheter passed gently along until about 20 centimeters have entered the vein. A saline manometer may now be connected to the catheter and a slow drip of heparinized saline maintained. For demonstration purposes, the saline is stained with Evans blue dye. Further manipulation of the catheter into the desired position is controlled by the X-ray screen. As we get dark adapted, the catheter comes into view in the upper part of the thorax. It is now seen passing through the left innominate vein, down through the superior vena cava, until it enters the right atrium. While it is in the atrium, the saline manometer shows relatively small pulsations at a level opposite the middle of the heart. The catheter can now be manipulated through the tricuspid valve into the right ventricle. As it enters the ventricle, pulsations at once become more vigorous and rise about 10 centimeters higher than the right atrial pressure. With further manipulation, the catheter tip will pass upwards into the pulmonary artery. And in this case, it enters the right branch. In this position, pressures rise a further 5 or 6 centimeters, pulsations remaining vigorous. For cardiac output estimations, samples may be withdrawn from any of these 3 positions in the right heart: right atrium, right ventricle, or pulmonary artery. In taking samples, the manometer connection is detached from the catheter and enough blood is withdrawn by a syringe to clear the catheter of saline. A change is then made to a special sampling syringe containing liquid paraffin, into which right heart blood is drawn. The catheter is then cleared by washing through with saline, and the manometer is reattached. An indwelling needle and stilette have meantime been inserted through the anesthetized skin into the opposite brachial artery. Simultaneously with sampling of blood from the right heart, an arterial sample is withdrawn. The blood rises into the syringe under arterial pressure, and very little traction is required on the plunger. Each sample is ejected from the syringe into a bottle containing dry sodium oxalate, and significant contact with the atmosphere is prevented by adding a layer of gas-free liquid paraffin. The sample is then stirred under the paraffin to ensure that the oxalate goes into solution and thus prevent clotting of the blood. The samples are numbered and kept on ice until analysis can take place. These samples are analyzed in a Haldane blood gas apparatus. A measured sample of blood is placed in the bottle under an alkaline solution which will absorb any carbon dioxide. After various precautions, this blood is shaken and exposed to atmospheric air in the bottle. During this shaking, oxygen is absorbed, and the absorption of oxygen is shown by a rise of the fluid level in a calibrated pipette. The amount of oxygen which is absorbed by the sample is thus measured directly. Any changes in temperature and pressure which take place during the procedure are automatically compensated by a control bottle exposed to identical conditions in the water bath. In actual practice, 3 cubic centimeters of alkaline borate solution are introduced into the Haldane bottle. The blood sample is again stirred to avoid errors resulting from sedimentation. Three cubic centimeters of blood are sucked into a stoppered Ostwald pipette and the pipette is wiped clean at the tip. The measured sample is gently introduced into the bottle, where it lies in a layer under the covering alkaline solution. A special bottle holder with an airtight screw cap is fitted, and the whole device, which is attached to a pivoted lever, is put into position in the water bath, where it is left to come to temperature equilibrium for a few minutes. When temperature equilibrium is ensured by testing during temporary closure of the taps of the apparatus, the taps are finally closed for the analysis. The reading on the scale of the calibrated pipette is exactly 0.500 cubic centimeters. The bottle is then shaken automatically by engaging a clutch, and the absorption of oxygen by the sample is indicated by the rising fluid level in the measuring tube. Complete saturation with oxygen is indicated by cessation of upward movement of this fluid column. Leveling tubes then adjust the pressure conditions to atmospheric, and the final reading of 0.350 cubic centimeters indicates that this 3 cubic centimeter sample of right heart blood had absorbed 0.500 minus 0.350, that is 0.150 cubic centimeters of oxygen. When an arterial sample has been similarly analyzed, we can calculate the cardiac output. The oxygen absorption in the spirometer tracing was 235 cubic centimeters per minute. The oxygen absorbed by the right heart sample was 50 cubic centimeters per liter, while the corresponding arterial sample took up 11 cubic centimeters per liter. Subtracting 11 from 50, we obtain the arteriovenous oxygen difference, which is 39 cubic centimeters per liter. Therefore, the cardiac output is 235 divided by 39, or approximately 6 liters per minute. As both oxygen uptake and arteriovenous oxygen difference are measured at room temperature, no significant error arises from omission of the usual temperature and pressure corrections. In addition to permitting measurement of cardiac output, the catheter enables us to take optical records of pressures within the heart. One satisfactory recording device is called a strain gauge. This consists essentially of a special type of wire which alters its electrical resistance when stretched. The stretching movements are, of course, grossly exaggerated in this illustrative diagram. Changes in resistance produced by pressure are used to deflect the galvanometer mirror using the Wheatstone bridge principle. These deflections are recorded on moving photographic paper. The apparatus is mounted on a wheeled trolley. The strain gauge is contained in an oblong box with arrangements for fluid transmission of pressures from the heart. A three-way tap permits easy switching to either the saline manometer or the strain gauge. A similar strain gauge may be connected to the indwelling arterial needle in the other arm. It is seen here with its connections mounted on a stand beside a pressure bottle containing sterile saline. When everything is ready, the switches on the recording trolley are turned on, and the beams of light from the galvanometers may be observed through a tunnel while they record on moving photographic paper. When the recording is complete, the switches are turned off and the paper is removed from the camera for development. Studies may then be made of the pressure recordings. Here is a developed photographic record showing from above down tracings of respiration, arterial pulse, and the lowermost record is the recording of pressures from the right ventricle, with the calibrated scale of pressures drawn alongside. The peak of pressure in the right ventricle is the same as the systolic pressure in the pulmonary artery. This record shows what happens when the catheter is drawn back from the pulmonary artery into the right ventricle. The dotted line shows the identity of systolic pressure levels, while the filling pressure of the ventricle is recorded at the end of diastole. Now here is a second method of estimating cardiac output. If a measured quantity of dye is injected into the fluid flowing through a model system representing the right heart, lungs, and left heart, The dye will be diluted as it is washed through by the flowing fluid, and it will appear in the effluent first as a highly stained fluid, followed by a slowly fading tail. In timed samples from an exit tube, the concentration of dye will rise steeply at first, and then the intensity of color will fall away. An estimation of the concentration of the dye in each timed sample permits the construction of a time concentration curve. Suppose capital I represents the amount of dye injected. From mathematical analysis of our curve, we can estimate the mean concentration of the dye, C. The amount of injected dye divided by its mean concentration will be the volume of fluid passing through the system during the time t. The volume flow per second will therefore be I over Ct. And the cardiac output per minute will be I over Ct multiplied by 60. In practice, this method is applied in the following manner. The amount of injected dye is carefully measured by weighing the syringe before and after the injection. Meantime, the patient is made comfortable and his right arm is placed on a pillow. His sphygmomanometer cuff is wound round his left arm. The position of the left arm is then fixed by strapping to a board passing under the mattress. The heparinized serum tubes in which blood is to be collected are mounted on a drum which revolves at a uniform speed. A piece of plastic tubing cut to a suitable length passes through an angled glass bend just above the collecting tubes. The arm is prepared by swabbing with iodine and injecting a local anesthetic over the brachial artery. Simultaneously, the right arm is prepared for the intravenous injection through a locally anesthetized area. A needle is now inserted through the anesthetized skin into the brachial artery. And the plastic tubing is connected to the hub of the needle. The blood is at first directed into a large boiling tube. A blank sample of venous blood is withdrawn from the right arm The syringe containing the dye is then attached. As the injection is made, the time is marked by a signal on the revolving drum, and the collection of samples of arterial blood is begun. These samples are accurately timed by reference to the time marker scale. When a suitable number of samples has been obtained, as judged from experience of the type of case, collection is stopped and the arterial needle closed by a stilette. Here are the centrifuged tubes. The timing of each sample is marked on graph paper wound round the drum. The graph paper taken off the drum is marked for subsequent plotting of dye concentrations against the time scale. To obtain adequate amounts for colorimetry, the dyed plasma is mixed with equal quantities of saline. The rising and falling concentrations of dye may be seen in the upper row of tubes. Two hematocrit tubes are seen on the right. Standard concentrations of dye made up in the same way are shown in the lower row. It will be noted in the upper row that dye appears in the fourth sample, reaches its maximum about the sixth tube, and then the concentration falls away more slowly, while after the 11th tube there is a secondary rise in dye concentration due to recirculation of blood containing the dye. Dye concentrations are read in a sensitive photoelectric colorimeter and the reading noted. The exact concentration of each sample is now plotted to make a time concentration curve. In this case, the recirculation causes a secondary rise before the baseline is reached. If, however, the concentrations are plotted on a logarithmic scale, the falling concentrations form a straight line, which may be extended to the baseline, giving the curve representing one circulation only. The formula for estimation of flow, I over Ct multiplied by 60, gives, of course, the volume of dyed plasma flowing through the system. This has to be corrected by the hematocrit in order to give blood flow or cardiac output. The output in this case was 6 liters per minute. Suppose the flow through our model is 6 liters a minute, and the mean time spent in passage through the system is 1/3 of a minute, then at any moment the volume of fluid in the system will be 1/3 of 6 liters, that is 2 liters. In the time concentration curve, a vertical line balancing the areas to its right and left cuts the time scale at the mean circulation time, mt. In man, this permits a calculation of the volume of the circulatory system between the point of injection and the site of arterial sampling. The major part of this volume is contained in the heart and lungs and can be called the intrathoracic blood volume. The two methods of estimating cardiac output are each subject to small uncontrollable errors. Charting simultaneous determinations by the direct Fick and the dye methods, a diagonal would represent complete agreement of the answers. The actual results in a series of such paired determinations cluster closely round this diagonal, indicating excellent agreement, since the standard error of any single measurement is about 6%. These new techniques have a special place in the study of difficult problems and patients in whom surgical operations on the heart are to be considered. In the course of such investigations, valuable knowledge on the behavior of the heart in health and disease is being built up. Further technical improvements will take place in the future, and we shall glean new for the better management of heart disorders.